So next my class is about the paracetamol poisoning. So for the paracetamol being poison, it should be taken as a toxic dose. Okay. So when it becomes a toxic, so if we take more than 200 milligram per kilogram as a single injection or over 24 hours. Okay. That is if a person over 50 kilogram weight is taking greater than 10 gram. Okay. Then we call it as a toxic dose. Okay. And also if it is taken as more than 150 milligram per kilogram over 2 consecutive days. Okay. That is if a person of over 50 kilogram is taking greater than 7.5 gram injection over 2 consecutive days. Okay. So this is taken as the toxic dose of paracetamol. Okay. And if when it becomes peak in the serum, okay, that is after 4 hours of injection, the serum concentration will become peak for this paracetamol. And if you take food, opioids or anticholinergics along with it, then this will delay the absorption. Okay. So next is about the mechanism of this toxicity. That is how this paracetamol is metabolized in our body. Okay. So first this acetaminophen. Okay. First we should know about the therapeutic dose. Okay. Therapeutic dose. In therapeutic dose, 90% of the acetaminophen is metabolized in the liver. Okay. 90% of the acetaminophen is metabolized in the liver to sulfate and also glucuronide. Okay. You can see the sulfate is metabolized to glucuronide and sulfate, and both are excreted in the urine. Okay, so that is the 90% of the therapeutic dose pathway, and the remaining 10%, 5% will also be excreted through the urine in an unchanged form. Okay, acetaminophen 5% will be excreted through the urine in unchanged form, and the remaining 5% will be going through this pathway and will be metabolized by the enzyme, which is the hepatic cytochrome P450. Okay, so the remaining 5% is metabolized via the hepatic cytochrome P450 enzyme, and it will be converted to NAPQI. What is NAPQI? That is N-acetyl B benzoquinone imine. Okay, that is the NAPQI. Okay, so our acetaminophen is converted to N-acetyl P benzoquinone imine, which is a hepatotoxic compound. Okay, adoru hepatotoxic compound aanu. Okay, so that is happening to our therapeutic dose. 90% is converted and excreted through urine, 5% is excreted in unchanged form in the urine, and 5% is converted to this toxic form. Okay, so when we are taking a normal dose, what is happening? Okay, when we are taking a normal dose, this NAPQI which is formed, okay, is rapidly conjugated. It is rapidly conjugated to hepatic glutathione and forming a non-toxic cysteine and mercaptate compounds, and that are excreted in the urine. Okay, so when we are taking normal dose, even if this NAPQI is formed, that will be rapidly conjugated by this hepatic glutathione and will be converted to non-toxic NAPQI conjugates like cysteine and mercaptate compounds and will be excreted in the urine. Okay, so what happens when we are taking a toxic dose? If the person is taking a toxic dose of paracetamol, what happens? Okay, we know that the first pathway, that is the acetaminophen, is converted to sulfate and glucuronide. So here we are taking a toxic dose. Okay, more than 200 milligram of per kilogram is taking here. Okay, so when you are taking the toxic dose, it will be converted to glucuronide and sulfate, but this pathway gets saturated. Okay, this first pathway that gets saturated, so the sulfate and glucuronide pathways become saturated. So this will result in an increased fraction of acetaminophen being metabolized by the cytochrome P450 enzymes. Okay, so when it gets this pathway is saturated, what happens? Okay, the acetaminophen that is metabolized by the enzyme cytochrome P450 gets increased. So this will lead to the increase in the NAPQI compounds. Okay, NAPQI compounds. So what happens? This NAPQI compounds gets to be metabolized by the glutathione, gets conjugated by the glutathione stores, and these glutathione stores are depleted. Okay, normally what happens? Normally when the NAPQI compounds are formed, this will be rapidly conjugated by the glutathione compounds and converted to a non-toxic compound. But here these glutathione compounds are also get depleted. So what happens then? This NYPQI compounds, that which is the hepatotoxic compounds, that gets accumulated Okay, because they are not get conjugated by the glutathione, and these free NAPQI compounds gets accumulated, and these will lead to hepatotoxicity. Okay, so that's the metabolism of toxicity. So next is about the stages of acetaminophen intoxication. That is the first stage, means that is from the 0.5 to 24 hours after the ingestion. So at this first stage, the patient will be showing the clinical features like nausea, vomiting, diaphoresis, pallor, lethargy, and also malaise. And some patients may remain asymptomatic. Okay, and while we are doing the laboratory studies, this will be typically normal in this first stage. Okay, and next the patient will be going to the second stage, that is from the 24 to 72 hours. Okay, on the day 3. Okay, here the stage 1 symptoms starting to resolve, and here mainly hepatotoxicity and also nephrotoxicity become, okay, hepatotoxicity and nephrotoxicity becomes evident here, and the patient will be having right upper quadrant pain, liver enlargement and tenderness will be there, and when we are looking the LFT, there will be elevation of the aminotransferases. Okay, that is mainly occurring within 36 hours of ingestion in patients with hepatic injury. Okay, 36 hours of ingestion in patients with hepatic injury, there will be an elevation of the aminotransferases, and also elevation of the prothrombin time and international ratio of PT, and oliguria and abnormalities of the renal function will be there, and also elevation of the serum amylase with or without a clinical pancreatitis may occur. Elevation of aminotransferases, elevation of prothrombin time and international ratio of PT, and also abnormalities of renal function and oliguria, and elevation of serum amylase. Okay, amylase with or without clinical pancreatitis may occur. So these all the main enzymes are increased in this 24 to 72 hours second stage. And next is the third stage. In third stage, that is from the 72 to 96 hours, here the liver enzymes and function abnormalities become peak. Okay, normally here this started from stage 2, the abnormality started, and in stage 3 these abnormalities that become peak. That is why we are looking the enzymes here. Now the enzymes are like greater than 10,000 international units per liter. Okay, and the recurrence of stage 1 symptoms, here in stage 1 symptoms, nausea, vomiting, diaphoresis, pallor, lethargy and malaise. Okay, like these symptoms were this, and these symptoms were again recurring in the stage 3, and also along with this there were jaundice, hepatic encephalopathy and hyperammonemia, bleeding diathesis, hypoglycemia and lactic acidosis. Like that symptoms are also there, and renal failure occurs, the incidence of which is related to the severity of the intoxication. Okay, and also death due to multi-organ failure, sometimes death also may occur. Okay, occurs most commonly. Okay, so death commonly occurs in this stage, only the death occurs, that is in the stage 3, that is from 72 to 96 hours. And stage 4, that is from 4 to 14 days, that is a recovery phase. Symptoms and laboratory values may not normalize for several weeks, but the recovery, this is the recovery phase, and histological recovery lags behind the clinical recovery and may take up to 3 months. Okay, histologic recovery in the clinical recovery that lag ചെയ്തുകൊണ്ടിരിക്കും, and maybe it will be taking like 3 months for the histological recovery. Okay, so the stage 4, that is from 4 to 14 days is the recovery phase, and stage 1, that is the clinical, like normal clinical features of paracetamol poisoning is shown by the stage 1, and stage 2, the hepatic injury, nephrotoxicity, all will be shown in the stage 2, and stage 3 all becomes severe. Okay, all becomes at the peak level, renal failure, liver functions, all liver enzymes and abnormalities all becomes peak in the stage 3, hepatic encephalopathy, bleeding diathesis, lactic acidosis. Okay, and even death may occur, that all occurs in the stage 3. So these are the stages of acetaminophen intoxication. So next is about the management of a paracetamol poisoning case. So first you should stabilize the airway, breathing and circulation, because it is an emergency condition, and after that you should do the gastric lavage. That is within 1 hour you should do the gastric lavage, and if the patient is presenting within 2 to 4 hours, then you can do activated charcoal. Okay, activated charcoal 1 gram per kilogram can be used in patients presenting with 2 to 4 hours. Okay, and here the antidote is N-acetylcysteine. Okay, NAC, that is the antidote here we are giving, because it helps in replenishing the hepatic glutathione. I said now the glutathione only convert this thing to a non-toxic. Okay, so this antidote, the antidote only converting replenishing the hepatic glutathione. Okay, this is the basis for treatment, determining the treatments. That means here the serum, we should look the serum paracetamol level, and that serum paracetamol level will be giving the basis for determining the treatment. Okay, and you should send the sample within 4 hours after the ingestion or immediately if time not known. Okay, so when a patient comes with paracetamol poisoning, you should manage that because it is an emergency condition, and along with you should do the investigations like liver function test, LFT, and also you should look for the PT-INA, okay, PAT-INR, and renal function, RFT, and also look for serum electrolytes, ABG, serum amylase, and serum lactate level. Okay, you should do these, mainly these investigations are the main investigations you should do in this case. So LFT, PT-INR, RFT, serum electrolytes, ABG, serum amylase, and the serum lactate. Okay, and in this case there is a protocol is there, that is the NAC protocol. NAC we know, N-acetylcysteine protocol, and there is oral regimen and also IV regimen for that. If it is oral regimen we are giving, then first 140 milligram per kilogram, then followed 4 hours later by 70 milligram per kilogram every 4 hours for a total of 17 doses. Okay, so total 17 doses കൊടുക്കണം മൊത്തത്തിൽ. അപ്പോൾ first you should give 140 milligram per kilogram, and 4 hours later you should give 70 milligram per kilogram. Then it is given every 4 hours for a total of 17 doses. Okay, that is the oral regimen. So next the IV regimen is here, at the total of the NAC should be diluted in a 200 ml of 5% dextrose, and it should be given through IV over 15 to 16 minutes. Okay, and also 50 milligram per kilogram of NAC. Okay, 50 milligram per kilogram of NAC which is diluted in 500 ml of 5% dextrose can also given, that is through IV over 4 hours. Okay, over 4 hours it should be given, and followed by 100 milligram per kilogram NAC that is diluted in 1000 ml of 5% dextrose, and it should be given through IV over 16 hours. Okay, so this is the IV regimen, and this NAC can be discontinued if the patient is clinically well and also the alt levels are decreasing and the PT-INR level is less than 2. Okay, then or the patient is clinically well, we can discontinue the NAC. Okay, and if the patient is not improving, or the while we look the paracetamol concentration, it is persistently high, that is greater than 10 mg per liter, or the alt level is greater than 50 international unit and it is increasing, then you should not discontinue it, you should continue the NAC. Okay, that is at 6.25 milligram per kilogram per hour. Okay, that the continuing unit. Okay, that's it. And there is another one thing also, that is the King's College criteria for the liver transplantation. So here the liver transplantation should be done if the pH is less than 7.3 or the arterial serum lactate level is greater than 3 millimole per liter. Okay, that is one condition. Or second, if all the following, like if the PT-INR is greater than 6, serum creatinine level is greater than 3.4 milligram per deciliter, or there is grade 3 or grade 4 encephalopathy, then you should do the liver transplantation. So this is the King's College criteria for the liver transplantation.